So for anatomy of the hip and pelvis, we'll begin up in the pelvic region. And the pelvis is comprised of three separate areas. So superiorly, we have the ilium, and we can see bony projection on the front of the ilium, the ASIS, very easy to palpate on each other or other people. And just a little bit inferior to it, we have another bony bump, the AIIS, anterior inferior iliac spine. And this is where your rectus femoris originates from. So the ASIS, anterior superior iliac spine, AIIS, anterior inferior iliac spine, and again, your rectus femoris originates from there. If we follow the iliac crest around posteriorly, we have a bony bump on the posterior surface of the pelvis, and that is the PSIS. And in a moment, we're going to be using that to landmark on each other pelvic levels and how our ilium moves slightly when we bend and flex or extend our hip. Lower portion of the pelvis, anteriorly, we have the pubic bone. Where the two pubic bones meet on each side, we have the pubic symphysis. So this would be another example of our syndesmosis joint. So tough fibrous joint, not a whole lot of movement that occurs there, but there is a tiny bit of movement, and there's opportunity for expansion of that joint during childbirth in females. The inferior portion posteriorly of the pelvis, we have the ischium. And the very bottom of the ischium, the ischial tuberosity, your hamstrings originate from there. It's sometimes called the sit bone. So when we're sitting right on our ischial tuberosities. Each section of the pelvis contribute to the acetabulum. So the acetabulum would be the socket here, and if we get rid of the femur, we can see how each portion of the pelvis, the ilium, the pubic bone, and the ischium all contribute a small bony part to the acetabulum, or the socket where the head of the femur sits in. If we look at the femur itself, we've got the femoral head right here, and then the more narrow femoral neck. And that's our most common location for femur fractures, is because the bone narrows there. We have large bony bumps on the lateral side of the femur, and that would be our greater trochanter right there. It's primarily there for muscle attachment. Our hip abductors, glute med, glute min, TFL, all attached to the greater trochanter. And then on the medial side of the femur, and a little bit more distal, we have the lesser trochanter right there. And that's where our psoas muscle, our hip flexor muscle, and iliacus, they attach to the lesser trochanter. If we follow the femur down, the shaft of the femur, we get to our femoral condyles that we looked at last week in the knee lab. So our medial and lateral femoral condyles. And then if we rotate around, so we're looking at the lateral side, where the femoral condyles stick out the furthest on the lateral side is our lateral femoral epicondyle. So in your lab notes, number 1, bones, A, femur, I, lateral femoral epicondyle. The reason we highlight it today is our iliotibial bands, thick band of connective tissue on the outside of our thigh, it travels right over top of the lateral femoral epicondyle, and it runs down and attaches to the tibia on the lateral side of the tibia. Where it attaches is a roughened area of bone called Gerdy's tubercle. So again, lab notes number 1, bones, letter C, tibia, Gerdy's tubercle. It's an area of bone on the anterior lateral tibia, where your iliotibial band attaches to. When we look at our joints, today we're primarily concerned with our hip joint. And so the hip is a synovial joint. Surrounding the joint, we have the joint capsule. And remember, we talked in lecture yesterday how there's three main areas of the joint capsule, and it's thickened to the point that they give it the name of ligaments. And how the ligament is named is going to depend on where it attaches to the pelvis. So the pubofemoral ligament is coming off the femur and attaching to the pubic bone on the pelvis. The iliofemoral ligament is running from the femur and attaching to the ilium, and the ischiofemoral is attaching to the ischium on the pelvis. So each of those ligaments are going to restrict certain movements at the hip joint. If we swing around to the posterior surface, again, we've got our ilium on each side, and if we can highlight here, we can see the sacrum, or the tailbone, the bone that fits in between the ilium, and it's the very bottom of our spine. We know the sacrum is composed of 5 fused segments. The joint between the ilium and the sacrum is our sacroiliac joint right here, and it's given the name of SI joint for short. There's not a whole lot of movement that occurs in the SI joint. The bones fit together very well, very tightly, and it's an example of form closure, so how well structures fit together. And in this case, the sacrum and the ilium on each side fit together very tightly, and it's a good example of form closure. There is a tiny bit of movement that occurs at the SI joint on each side, again, to allow us to squat and bend and flex our hip or extend our hip. And in a moment, we're going to be assessing that on each other, landmarking our PSIS on each side, and then having a partner or family member bring one leg or thigh up into hip flexion and seeing how the ilium on that side moves, and then comparing to the other side. So we're going to move on to our muscular anatomy now. And we'll start with our hip flexors. Now, to see our primary hip flexors, we need to get rid of some of our core musculature. So our external obliques and internal obliques and rectus abdominis and transversus abdominis, in order to see their deeper muscles. And so here is our psoas, and it actually comes off of the lateral side of the lumbar vertebrae. So our transverse processes, those little bony projections that stick out the side of the spine, that's where your psoas originates from, and it travels all the way down to attach to our lesser trochanter. Iliacus, so it comes off the inside of the ilium. The iliacus and the psoas share the same tendon to attach to the lesser trochanter. So the primary job of those two muscles is hip flexion. They're very strong hip flexor muscles. Helping with hip flexion, rectus femoris. So it's one of our quadriceps muscles, and when we think of quadriceps, we think about knee extension, but rectus femoris, because it comes off of the AIIS on the front of the pelvis, rectus femoris can also help with hip flexion. If we get rid of rectus femoris, now we can see our 3 vastus muscles, our vastus lateralis, our vastus intermedius, which is right underneath rectus femoris, and then vastus medialis. So all 3 of our vastus muscles come off of the femur. They don't cross the hip joint. So the only thing the vastus muscles do is help to extend the knee. We'll look at our hip extender muscles, and our primary hip extender is glute max. So very big, strong muscle, runs down and attaches to the lateral femur. When it contracts, it helps to extend our hip and propel us forward if we're walking or running. If we go deep to glute max, we can see our hamstrings on the posterior thigh. So on the lateral side, we have biceps femoris, runs down and attaches to the head of the fibula. And on the medial side, we have our semitendinosus, and deep to it, semimembranosus. And they run and attach to the medial side of the knee. I'll mention again pes anserine, that area right on the medial side of the knee, where our three muscles attach. So semitendinosus, and we'll look at the other two muscles in a moment. Now, our hamstrings' primary job is to flex the knee, but because they attach to the bottom of the pelvis, the ischial tuberosity, they also help with hip extension. So glute max, primary hip extender. Our hamstrings help a little bit with hip extension. So that's why we're talking about hamstrings again today. For our hip abductors, deep to glute max, we have gluteus medius coming off the ilium and running down and attaching to the greater trochanter, and deep to that we have gluteus minimus. So it's about halfway down the ilium and again attaching to the greater trochanter. So hip abduction, think about lifting your leg out to the side. How often do we ask our body to do that? Not too often, but where those muscles are more active, gluteus medius, gluteus minimus, and even TFL, another hip abductor, is when we're walking or standing. With every step that we take, those muscles have to contract to keep us upright when we're standing on one leg so we don't tip over to one side. So those muscles are very important, and if we have weakness in those muscles, it can allow more movement in through the femur and allow the knee to collapse inwards into a valgus position or knock-knee position, which can contribute to knee injuries. TFL comes off of the ilium, but it actually feeds into our iliotibial band, which is a collection of fascia or thickened fascia on the lateral side of the thigh. And we know the iliotibial band goes down and attaches to our Gerdy's tubercle right here on the lateral side of the knee. Sorry, we'll just get that. Yeah, not letting me draw right now. But anyhow, iliotibial band attaches to the lateral side of the tibia at Gerdy's tubercle. On the medial side, for hip adduction, we have our adductor muscle groups or groin muscles. So adductor longus, we have adductor magnus, and deep to adductor longus, we have adductor brevis. Okay, so those three muscles all come off the pubic bone and attach to the medial sides of the femur, and when they contract, they're going to squeeze our legs together. Again, when we're walking, when we're running, our hip abductors on the lateral side and our hip adductors on the medial side of the femur work together to help keep us balanced and upright. Gracilis has the same path of travel as the adductor in that it comes off of the pubic bone and runs down the medial side of the knee, but it's another muscle that inserts at the pes anserine, and it helps to stabilize the knee medially. We talked about how well the bones fit together with our form closure. We're going to talk about something else, and that is our force closure. Okay, so how well the muscles work together to squeeze the joints together or help to stabilize. So earlier we got rid of our external oblique, but here's the orientation of the muscle fibers here, kind of the same angle that your fingers would take if you're putting your fingers in your pockets. The muscles stop in the middle with the linea alba and they attach to the pubic bone here. Our adductor muscles on the opposite side of the pelvis and below, coming off the bottom of the pubic bone, this is the muscle fiber orientation like this. And we think of muscles starting and stopping in one place or another, but the fascia, the thin layer of tissue that surrounds it, is continuous with each other. So we have these muscle connection that overlap either side of the pelvis, and then we would have the same thing from the other side. So we have this X pattern at the front of our pelvis where the muscles squeeze together to help stabilize the pelvis, and that's an example of our force closure. If we do or look at the posterior surface with some of our muscles, and here's latissimus dorsi, which is a huge, strong muscle on our back, and there's the orientation of its muscle fibers. And then our glute max on the opposite side, and the orientation of its muscle fibers. Again, with the fascia, the coating around the muscle, it's continuous with each other, and we would have the same thing on the opposite side. So we've got that same X pattern on the posterior surface of the pelvis. And when the muscles work together in a coordinated fashion, they help to squeeze and stabilize the pelvis, and again, our force closure. When we have a strain in a muscle, say in the low back, or maybe we strain glutes on one side, then that mechanism doesn't work as well, and we can start to get other muscles that are being asked to do more work, and then they start to get overused and irritated, and the tendon becomes irritated, or maybe they're pulling on the bone at their origin and the periosteum gets irritated, or we start to get our microfractures, especially with our muscles that attach to the pubic bone. And that's the beginnings of our sports hernia, where we strain one muscle that contributes to this force closure. It increases the stress on other muscles, and we get a breakdown in the whole system, and sports hernia may be one of the results of that. Some of you may have heard somebody say that their iliotibial band is tight, or they need to stretch out their iliotibial band. Well, that's not really accurate, because your iliotibial band is a collection of fascia, or thickened fascia, on the lateral side of the thigh. But we have TFL, tensor fascia lata, a muscle that feeds into the iliotibial band, and right underneath the iliotibial band on the lateral side of the thigh, we have our vastus lateralis. Now, it's very common for vastus lateralis to be tight, and sometimes people can have some tightness in their TFL. So that tension from those muscles can be passed through into the iliotibial band, and sometimes the iliotibial band can even be stuck to the outside of the vastus lateralis. So if those muscles are tight, it passes tension down through the iliotibial band to where it pulls on the attachment at Gerdy's tubercle and the lateral tibia, and it starts to get sore and irritated, and that's our iliotibial band friction syndrome, one of the injuries that we'll look at today. So while you can't stretch out your iliotibial band, you certainly can stretch out TFL, or you can try to loosen vastus lateralis underneath the iliotibial band. So if you hear somebody say their iliotibial band is tight, not 100% accurate, but that's what they're referring to. So that's it for our anatomy for today. Again, in a moment, you guys are going to be palpating different structures on each other. I'll show that in a separate video. And then as well, you're going to assess mobility through the pelvis using your PSIS to landmark, and then having partner or family member flexing hip and extending hip, and see how our ilium moves on the sacrum.